So, oh, Jesus. All right, so I hope that you all are upset by how many tabs I have open, because I am. Last we left off on the weed, we just started touching on the concepts of weed and white privilege, but we didn't finish, so I just want to get this like done. Water is life. So I want to show you guys this really interesting interactive thing in a second, but first, just like switch your brain back to weed. I know that's kind of jarring. It's been like a week and a half since we did this, but this is a kind of like weird abstracted map of basically the racial disparities in arrests for weed. And you can see different states obviously have different purple levels. Like a darker purple hue indicates a higher ratio of likelihood of arrest based on being Black, basically. So for instance, in Kentucky, if you're Black, you are 10 times more likely to be arrested for weed. 10 times more likely to be arrested for weed. Now, like I said, statistically speaking, Black Americans and white Americans smoke weed at approximately the same rates and sell weed at approximately the same rates. So there is only one reason for this, you know? This map does the thing to my eyes where it makes black dots between the squares. Well, this is also a class about optical illusions, in case you guys weren't aware. So that's exactly the intention. So this is just like the initial data point that we can use to be like, oh, there is like, this is irrefutable. And this is one of those things where whenever people try to be like, oh, the war on drugs is about substances and like how dangerous a drug is, you pull up a map like this, and if someone doesn't get it at that point, it's like, what else do you want from me? Like, this is so cut and dry. This is so simple and obvious. The ratio of arrests for Black people who smoke weed and do drugs in general as compared to white people is insanely skewed. It's like appalling. And it also, again, like I said, is a reflection of a system that is working as intended. And we'll come back to this when we talk about incarceration and private prisons and prison labor in particular, and how lucrative prison labor is. The nutshell of what we're going to get into very soon is that it is incentivized to incarcerate people because it makes money. And again, this is not a conspiracy theory. This is like by the books, like quantitatively, people are shaking hands in corporate offices being like, thanks, good to do business with you. Because it's a lot easier to convince yourself that someone is a dangerous drug addict in need of work rehabilitation when they're going to be making your cheese for you for Whole Foods. That's right, Whole Foods, which is owned by Amazon, has prison labor making its cheese, as well as many other companies. Just another reason to shop at Trader Joe's instead. So here's just like another graph from the ACLU, the American Civil Liberties Union, which is an awesome organization. If you're not familiar, you should sign up for their mailing list. Basically, like, again, nutshell ideology of like how these things are so skewed. But here is this website by the ACLU is an awesome immediate graphical representation of this phenomenon. You can sort it by state, and you can see how much more likely your Black neighbors are than you, if you're white, to be arrested for doing maybe the same shit that you do. So let's look at my home state of California. Okay, 1.8 times more likely, despite the fact that weed has been legal for years. But then you go up to Montana, where weed is like super, super criminalized. And Kentucky and Illinois, the Midwest in particular, is like huge danger zone. The Midwest and whatever that weird area of the country is that contains the Dakotas. Does anyone know what that's called? Because historically I've called it the Midwest or the middle armpit, but and like, no hate, you know, I've spent a lot of time in all of the states that are in that region. I've driven through a lot of them, but man, Iowa and Nebraska, those things are crazy. You drive through them for 16 hours and you can't actually tell how far into the drive you are because the scenery doesn't change. Anyone in here from Iowa or Nebraska? The plains. Thank you. That's exactly what I was looking for. The plains. Like, you're from Nebraska? Man, okay, so I've had some really, really awesome experiences in Nebraska, but the drive on I-80, like, no matter how dope other areas of Nebraska are, the drive on I-80 is like the 7th layer of hell. Do you agree or disagree with this? Let's talk. I'm taking opinions here. Okay. So, Can't see the chat. Good view of the sky. That is totally true. That is totally true. Okay, so this is another issue here that we're looking at, is that as weed begins to get legalized in different areas, and as people are able to start opening their own weed-oriented business and dispensaries and groweries and trimmeries and whateveries, like Dr. Seuss book, the vast majority of business owners are white. Like the vast majority of business owners, 80-something% of cannabis business owners are white. How did this happen? Well, you see, it's extremely expensive to open a weed business. Like there are so many regulations in place. So this has set up an industry exactly like we're seeing with psychedelics right now. This is why I don't support decrim movements for the most part, unless you're doing like a full decrim like Oregon did. Yay. This is exactly what we want to avoid, basically. If we have a relatively even amount of use across racial demographics, and if we have an extreme skew in which racial demographics get incarcerated for doing the same thing, and then we suddenly make it legal, and out of nowhere, everyone that already hasn't been getting penalized for this is now able to also profit off of this, that's a problem. So what we're trying to do in a lot of these movements that are going for like legalizing weed in different states, like we're seeing this battle in New York right now of like, how are we going to use these funds that we make from legalizing stuff? The problem is that like those funds are not being allocated towards reparations, and also are not being allocated towards a fund for BIPOC business owners that want to like actually profit off of doing the same shit that they've been doing this whole time for many of them. Something to keep an eye on. Quick harm reduction for weed. Be mindful if you're in a state that is not legal or recreational, you are much more at risk of buying synthetics unknowingly. If you take a hit of your bowl or your joint or whatever, and it tastes like really chemically and weird, it is probably not weed. You know, if it's like really gross and it tastes like metal or something similar, then like you should be mindful of that and probably put it down and wait a while before hitting it again. If you like smoking synthetics, that's your choice. You know, like some synthetics are perfectly enjoyable recreational drugs for some people, but synthetics as a whole are so new and so unregulated that, yeah, there's totally a risk of having like internal bleeding and psychosis acutely. Like those things happen from synthetics. In fact, synthetics are infinitely more likely to cause physiological effects than non-synthetic cannabis. Wouldn't it be nice if there was like a legal alternative to synthetic cannabis that didn't have so many side effects? I don't know. That's just like just food for thought, you know? If you smoke for a long time, you could possibly have ouchies in your lungs. We don't really have that much data on this, but like try a different method if you can. Like I hate that I don't know what Google Slides did. I'm not this kind of person. I would never present a slide to you where something was off center within a bounding box. That is just like not my status quo. So I'm sorry. If you can, change your route of administration. Maybe switch from smoking weed to edibles if you like the feeling of edibles, keeping in mind that edibles do create a different version of THC, basically within you, 11-hydroxy THC. Check your privilege. Check your fucking privilege. If you're a white person who feels comfortable driving to a Walmart parking lot and rolling down the windows to smoke a joint with your friends in the middle of the night, you should really think about that. You should really think about the fact that you don't have to think about anything when you do that. Keep in mind, white privilege is what you don't have to think about. You can have a billion things stacked on your plate and you can have it really rough, but if you're white, you would have it rougher in those things if you were not white. So like that's really the basis of this, is like a lot of people get really riled up about this notion of being accused of being privileged, and they're like, I have XYZ bad thing going on. And it's like, that's not actually the point. The point is that it would be probably a lot harder because there would be systems in place specifically to make it harder for you. So keep that in mind. Edibles feel different. They tend to last quite a lot longer, like 4 to 6 hours instead of 2 to 3. And they tend to hit you quite a bit harder proportionally. I I personally find Dr. Carl Hart has been releasing some really interesting commentary about how a really powerful form of activism is to talk about your own drug use. So Mazel Tov, I'm going to be publicly talking about my own drug use during DrugsCo from now on. So I will share my own experiences with these things. I'm a person who uses drugs. I'm a person of privilege who uses drugs. People who use drugs deserve human rights. So in terms of edibles, I personally find that edibles tend to be a lot less like sleepy depending. But they can also, the effects are just different, you know, like I think that a lot of the time there's a little bit lower of a likelihood for like intense stoniness and confusion, but it also kind of depends on the specific edible that you're eating and your dosage. So that's kind of like you personally should try both routes if you're interested and just like see which one you prefer. Please don't drive if you're high. Everybody and their mom thinks that you can smoke a joint and be baked as hell and get behind the wheel and nothing is different. Statistically, quantitatively speaking, it's different. Your reaction time is slowed. You can wait an hour. You know, it's not that long to wait until you're not as baked. And also be really mindful of your mental health with smoking weed. For some people, smoking weed can be really, really useful for a lot of things. For other people, smoking weed can become a really, really big psychological no-no. So keep that in mind for yourself because, again, it's like there is no single substance that is the cure-all for all different ailments. And a lot of people tout weed as being the cure-all, but it can actually really make your anxiety worse if you're smoking weed all the time for anxiety, you know? So just keep tabs on that. And also if you have a family history or prone to psychosis, if you also tend to get paranoid when you smoke weed, be really, really mindful of that. Be careful there. That's enough of the weed. Let's move on to the, this one. Okay, last we left off, we were talking about the different potential consequences of injection. Yes, Jackson said edibles get processed into 11-hydroxy-THC, which has a different psychoactive profile than delta-9 THC, which is the THC derivative that is typically processed by smoking it. So they are different psychoactive substances. Good to keep in mind. Yeah, these edibles ain't shit. 30 minutes later, exactly. You better be really careful with edibles. Click one and done. Like, I swear to God, I don't remember the last time that someone around me was like, man, I don't really feel this edible. Should I take more? And everyone was like, no. And I do not remember a time in the last like 2 years where that person an hour later hasn't been like, man, I could order Domino's right now. I'm really glad I didn't eat the rest of that edible. So be careful. Otherwise, you will end up like my housemates and there will be a lot of Domino's in the house. I've been so fucked up off of edibles. Yep, edibles can really get you. I personally take 2.5 milligrams of THC, and that is enough for me. 2.5 milligrams. That's basically nothing for most people, for many people. So last we talked about injection hazards from different processes, but now I want to give you kind of a firsthand insight. CG Kid, great YouTuber, very, very brave for putting his personal stories about these things on YouTube, about his experience with heroin.
Like they ask what's the most dangerous drug? It depends on the person. Some people try heroin, but they drink out of control. And for them, alcohol is more dangerous because they would never even use heroin in the first place. Also, it's based on genetic predisposition.
I'm just going to speed it up because that's the kind of mood I'm in.
I'm more of a tweaker. I react differently to stimulants and prefer them over downers. So meth is more dangerous for me. Heroin is the most dangerous downer that I ever experienced because I loved it, even though I'm not a downer person. Absolutely loved heroin. My second favorite drug, and I didn't use it for very long, which is crazy. I used it for 4 months. And the reason I didn't use it for very long is because, and I talked about this in another video, is it was never enough until I was overdosing. Like heroin has a weird way, and I always knew it's dangerous and you can overdose, and I would prepare my dosage and go into it knowing I would actually test the purity of it by doing a very small amount and saying, all right, this is what this feels like. 3 of these should be okay. But whenever I got 3 of those and got what would be like a heavy dose, I always wanted more. And it's weird with heroin is it makes everything less important, even your own life. And the only thing that's important is reaching a certain level where you're content with how high you are or how, out there you are. And for me, I was never content until I was basically on the edge of death. Like I was nodding out, barely able to breathe, then I loved it. I fucking loved it. What was the experience of it like when I was at that near death state? Heroin is fucking, I want to say it's not psychedelic and it's not a psychotic, but it's a visionary substance, which was so weird because nobody ever told me that. Like going into heroin, I thought it was just something that made you really relaxed. And when people are nodding out, I thought they were just kind of like falling asleep or feeling really chill. But you actually, when you're nodding out, especially on heroin, more so than with Oxycontin or any of the other opiates, I would go into like visionary states and like see things that made perfect fucking.
Hello? Okay, that's fine then. Yeah, that's a really major thing with a lot of opioids, particularly heroin, because of the intensity of the onset of it. But you can really kind of achieve a similar effect with other opioids as long as you are doing them in such a way that increases the blood concentration really rapidly. So you get like a rush. It's not quite the same generally unless you're just on a high dose, like a prolonged high dose of Dilaudid, for instance. Dilaudid is hydromorphone, I believe. And keep in mind, remember that heroin is actually broken down in the body to 3 different things. The main thing being morphine. Okay, heroin is basically a delivery vehicle for morphine. The only real difference between them is that heroin is also broken down into 6-MAM and 3-MAM, which are 2 metabolites. 6-MAM is a psychoactive metabolite that has its own kind of set of effects. Some people speculate that it makes heroin more euphoric than morphine, but in blind tests, people have like preferred them equally, interestingly. So it could be that there isn't really that much to 6-MAM. So heroin and morphine are pretty comparable substances, except that heroin has, I think, a greater bioavailability when you inject it. So when you inject heroin, I think I mentioned this last time, heroin is fat soluble, not water soluble. So when it goes into your bloodstream, it can immediately cross the blood-brain barrier, which means it gets into your brain and latches onto the receptors and it gets like broken up in the brain into its different metabolites that then get processed. So you have 6-MAM doing its thing, you have morphine doing its thing, you have 3-MAM being useless. I don't know what the point of 3-MAM is. And that is like how you get a huge concentration all at once. If you eat heroin, someone actually messaged the Discord about this. Yes, you can eat heroin, but it's not very common to eat diamorphine because it has to do first pass metabolism, which means it gets broken down in your liver. That's the first pass, goes through your gut, gets broken down in your liver into different stuff. So the liver is like the hot spot of breaking a big thing into smaller things. And oftentimes those smaller things are the things that actually do something in your body. So that's part of the reason why you have prodrugs like psilocybin gets broken down into psilocin. It's called a prodrug because through first pass metabolism, this original drug psilocybin gets like chopped up in the liver. And then whatever is the product is in your bloodstream. And that's what actually does the thing. So the first pass metabolism is part of why it takes so long for drugs to hit you when you eat them, as opposed to snorting them or smoking them or injecting them. And the solubility of that drug, whether or not it will glom onto water or glom onto fat, really determines how well it will be absorbed in each of those ways. It's really complicated stuff, you know? So this is a really major way that people kind of decide what opioid is right for what situation. Is it fat soluble? Is it water soluble? Is it more bioavailable orally or intravenously? Is it going to take this long to kick in? Is it going to have these metabolites? And how long will it take those metabolites to get processed? So when you see all these different opioids and you're like, these seem like they're basically the same thing, they look like it and it makes sense that they look like it. But the reality is that they each have like a slightly different way of interfacing with your body because of the molecular structure. So the structure is really crazy important. The structure effect interface is super important. Is morphine not fat soluble? I believe it's oh man, like I know this. It's just like these facts are kind of like melding in my mind right now. But I believe that it is that morphine is less fat soluble than heroin. So therefore, I think I mentioned this last time again. In some situations, it makes more sense to inject diamorphine, heroin, than morphine because it will be more effective. Something like that. I don't remember exactly. What was I getting at here? Yes, so the dream states. this is like a phenomenon across opioids, is these hypnagogic states where you are kind of like, it's like that feeling of being almost asleep. You guys know what I mean? Where you're like on the brink of falling asleep and you have these like really weird dreamscapes that unfold and you're like living alternate lives and you snap out of it and you're like, fuck. And that can also happen when, especially on a high dose of MDMA, when you're coming down off of it. Has anyone here experienced that before? Actually, you don't have to out yourself. You know, I've experienced that before where coming down off of a really, really intense roll, you're sitting there, you're like lying there, and you just like go off on this trail and you snap out of it and you're like, oh, don't really remember where I am right now. And then you slip right back into it. And that's especially bad when you're really sleep deprived. And that's I think an interesting window actually into psychosis, into the experience of like having a momentary lapse in terms of your processing of what is reality and what is not. TLDR, heroin, basically morphine with extra steps. Ta-da! So when looking at the different opioids that are available on the market right now, we have morphine and oxycodone. Heroin is more potent than morphine. Like the delivery of heroin is more effective than morphine because you can really just pack it all in there. Oxycodone is the next step up from morphine, followed by morphine IV. Again, the dose, like how you administer these things, is going to be really important. Then we're not going to talk about a lot of these. Then you have methadone, which we will talk about. All the way down here, we have heroin, hydromorphone, oxymorphone, all these different things, 7-Eleven, and then buprenorphine, and then fentanyl. So way down at the end here, we have fentanyl. And looking at that, you'd be like, whoa, fentanyl compared to morphine is like, wow, that's crazy. And it's true that a dose of 1 to 2 milligrams of fentanyl is likely to be lethal if not treated. Milligrams, okay? For those of you that are not familiar, a milligram of fentanyl is like basically the equivalent of a grain of sand. It's tiny. So you look at that and you're like, whoa, that's huge. But then you look at it, it's like, there's always a bigger fish from the worst of the Star Wars series. Then you look down here and you see that fentanyl, big boy fentanyl, is like small fish compared to carfentanil. And carfentanil is a lethal dose that is like, I can't remember exactly how much more potent. I think it's like 100 times more potent than fentanyl, which is 100 times more potent than morphine. And that's like, uh-oh, really bad. We've actually seen carfentanil on blotter in the United States. Test your blotter, guys. Like the likelihood of you getting a carfentanil blotter from the darknet is really low. But holy shit, would that not suck so bad? Like it doesn't take very much to test it. It's literally like the tiniest corner of your tab. It's like 5 micrograms worth of acid, assuming it's acid, not carfentanil. Just like, please test it. It really does not take very much. Fent test strips, yes, catch carfentanil. It's one of the analogs that our fentanyl test strips do catch. Okay, quick look into prescriptions, and I say this kind of generally speaking, but like opioids, I don't think really should be divvied up based on like heroin and prescriptions. But the fact is that heroin isn't really a popular prescription. It exists as a prescription, but it's really not popular. It's just not as good at what it does in terms of like medical pain relief purposes as other existing opioids. You know, it works. It just isn't ideal comparatively. So we have the classics, we have Perks, and Percocet or OxyContin are brand names. Again, we'll talk more about this when we get to the pharmaceutical industry, but the brand name is like specific guy went in and patented this generic ingredient in a certain form, maybe with other stuff in it. So this is oxycodone is the generic ingredient. Oxycodone is the chemical. Percocet or OxyContin are 2 brand names that have a certain kind of configuration of oxycodone within them. Maybe it has acetaminophen / Tylenol in it. Maybe it has a certain amount of binder in it that gives it a kind of release timing. Then you have Duramorph, which is the brand name for morphine, and Vicodin, which is the brand name for hydrocodone, and codeine, which is codeine, which is helpful. So real quick, just to make this pretty clear, morphine, there's a whole class called the morphinin class that is basically like, it shares the morphine-like structure. And again, as with, for those of you that hate chemistry, I'm with you. Until recently, because I've been reading PCOL, which is phenethylamines I've known and loved, and that is making me want to add chemistry to my very long lists of professions that I will never have. So morphinins are like, again, kind of similar to phenethylamines and tryptamines. Remember, phenethylamines is like the structure, the skeleton of the molecule is shared. Therefore, you can kind of get an idea for what it might do based on that core structure of the molecule. So this is helpful if you're looking at one molecule and another molecule, you're looking at like LSD and DMT or whatever. That's totally not helpful. If you're looking at DMT and serotonin, because DMT is basically like you're smoking serotonin. Isn't that crazy? It's like basically what you're doing. Tryptamines share a common backbone with serotonin. So you can look at that and be like, oh, interesting. That's how it does its sneaky thing, because it can fool your brain pretty effectively into being like, look, serotonin's come to play, but it's actually DMT. And then you're just like blasting off in your bedroom. Your brain didn't even see it coming. So this morphine oriented class is split kind of into categories of semi-synthetic and fully synthetic. So they basically look at morphine and they're like, okay, this is lit. We love morphine. It's very useful. We can do more things with this. We can maybe make it better. So on the semi-synthetic side, we have things like codeine and diamorphine, which are heroin. And then on the fully synthetic side, you have hydrocodone and oxycodone. There's a bunch more. This is basically, like I said, the morphine class is most likely going to act on mu opioid receptors. So that's a good thing to know, is that the mu opioid receptors, like the quintessential, this has opioid activity. Now, an interesting way that this is useful is looking at something like tramadol. How many of you are familiar with tramadol? How many of you have like heard of tramadol in the first place? I can only see 2 of you right now. So like, I'm just cool. I'm just going to assume that some of you haven't, some of you haven't. I believe codeine and tramadol breakdown are affected by CYP2D6 levels. Are any other major opioids affected by enzymatic levels? I believe so. I believe so. Also, fishy carfentanil has indeed circulated more recently than that. Like in 2020, it was around. DanceSafe is indeed releasing instructions on testing tabs, although you can also just DM me and ask. I gave tramadol to my dog with bone cancer. We just get all kinds of stuff in this chat. So tramadol doesn't fall into this category. Tramadol is an opioid, but it doesn't share this morphine-like structure in the same way that the others do. Tramadol is a weird atypical opioid. And interestingly enough, it acts on serotonin and norepinephrine and dopamine, which gives it stimulant properties and also means that it lowers the seizure threshold, which means that sometimes people who are going through benzo withdrawal, for instance, who've heard that opioids can be useful for getting through benzo withdrawal, might take tramadol and have a seizure because their seizure threshold is lowered even further. So, important thing to know. Traditional opioids like morphine and opioids are not likely to do that. Tramadol, which is an opioid but not sharing this backbone, is not as likely to do that. Yes, tramadol has a ton of interactions, and withdrawing from it is a bitch and a half. So real quick, some general things about each of these. Morphine is like the mother structure. It's the basis of a lot of opioids. It's like the quintessential opioid. And then codeine, which is also a naturally occurring alkaloid in the opium plant. Codeine is like direct from source, basically, but with some synthetic things added in the process. Typically dosed 100 to 150 milligrams, which is basically the highest of any of these opioids. Like tramadol, you have bigger doses. But there's this interesting thing that happens. It's called the ceiling effect, which means that for opioids, codeine in particular seems to have this effect. Once you hit a certain point of doing certain opioids, you kind of max out on the effects and you just get the negative effects after that point. So with something like codeine, that ceiling is thought to be between 200 and 600 milligrams of codeine, which is a big range, but it's usually around 400 milligrams. So this is something that people sometimes stumble across, where because of the way that codeine is metabolized, if you drink a ton of it or eat a ton of it, it's just going to like not really get you any higher after a certain point. So it has kind of that like self-taper. Codeine is a weaker opioid among these. It's not going to get you quite as high physically or mentally. It is the #1 most used opiate in the world. That means it's a naturally occurring, naturally derived opioid. And it is the predominant ingredient in lean. Codeine and promethazine is a combination that's usually found for cough suppressant purposes. You mix it with soda. Which soda? Which soda? Oh my God, why is this not? Someone help me. Sprite, thank you. Thank you very much. Say soda, who is she? And then there's diamorphine, which is heroin, right? And the dose of heroin for many things is dependent on route administration. Again, if you're injecting it, it's going to be the lowest dose, smoking it, second lowest, snorting it, third lowest, eating it, fourth lowest. Boofing it, that's a wild card. And generally speaking, morphine and heroin have approximately similar euphoric components. Actually, morphine, heroin, and oxycodone or oxy have very similar euphoric and physical properties. So when people are using oxy, it's a pretty comparable experience to using heroin. Like these have different levels of sedation and different levels of like relative cognitive euphoria to physical euphoria. Those are like minor differences, but generally speaking, the experiences are pretty similar. Then you have hydrocodone, which is in Vicodin. Hydrocodone tends to be a little bit less euphoric, but also a little bit less sedating, and is almost always packaged with acetaminophen. And that's a problem, because if people's drug of choice is hydrocodone in the form of Vicodin, then you're going to be consuming a lot of fucking Tylenol. And Tylenol can kill you if you use it regularly. Like actually, if you're taking like large regular quantities of Tylenol, your liver will fail. And in fact, we had a family friend who died from using Tylenol every day for 4 years. Like, it's really quite hard on your liver. NSAIDs too, super hard on your stomach. Remember, if you're going to take pain medications, like over-the-counter pain medications, do not mix NSAIDs. That means don't mix Aleve and ibuprofen, but you can take Aleve and Tylenol at the same time. They have different mechanisms, so keep that in mind. And then oxycodone, brand name Percocet. Again, it has very similar properties to both morphine and diamorphine. And this would make sense because diamorphine is converted into morphine. Yeah. Hello.
Welcome to 2-Minute Neuroscience.
Let's take a look at vanilla Faygo instead of Sprite. Wow, that's quite a combination. Okay, let's do a quick look into the like more nitty gritty of the neuroscience of opioids real quick, just so we have this under our belts.
Where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss opioids. The term opioid refers to substances that bind to opioid receptors, usually to exert pain-relieving effects. Opioids can be found naturally in the opium poppy, or they can be partially or completely synthetic. In addition to pain relief, opioids also cause sedation, anxiety reduction, and euphoria, along with a variety of other effects. When opioids bind to opioid receptors, they promote potassium conductance, which makes a neuron less likely to fire an action potential. And they inhibit
basically less electricity goes through it.
Calcium conductance, which makes a neuron less likely to release neurotransmitters. What effect these actions have depends on where the receptors are found. When opioid receptors on neurons in the spinal cord that carry information about pain are activated, it can inhibit the transmission of pain information to the brain. Opioids can also act on descending pain modulatory systems to reduce pain. For example, by binding to receptors in an area of the brainstem called the periaqueductal gray, opioids can prompt the inhibition of pain signaling in the spinal cord via a pathway that first synapses in the medulla. Opioids can reduce the emotional impact of pain by acting in brain regions like the anterior cingulate cortex, and they increase dopamine levels in areas like the nucleus accumbens, which may contribute to the reinforcing qualities of the drugs. Exposure to opioid drugs leads to tolerance, which involves a decreased response to the drug and a need to take more to produce the same effect. The mechanisms of opioid tolerance aren't fully understood, but they're thought to involve adaptive changes like a reduction in the number of functional receptors for the drug to act at. Adaptations in response to the presence of the drug also lead to dysregulation when the drug is removed, and withdrawal effects that are opposite in many ways to the typical effects of the drug.
We'll look more into that in a minute. I gotta go fast. I'm slow always. When you get an opioid in a pill form, or really anything in a pill form, it's pretty typical that people can, oh my God, I hate when Zoom puts the little video thing on the bottom and then I can't move it. So stressful. All right. So typically opioids in pill form are going to be crushed and then dissolved and dissolved and injected, or they'll just be crushed and snorted directly. Jackson, I just can see your dog just now, and I can see its little tongue sticking out. Wow. Wow. Oh, so cute. Or they can be smoked, or you can just eat them. Now, in terms of pop culture, there has been a huge influx of media interest and attention to opioid consumption in recent years, specifically within rap culture. Codeine in particular, lean, has been deeply popularized, especially as being a very exclusive drug experience in areas like Florida and Texas. Mask Off, for instance, Molly Percocet, Molly Percocet, woo, is a great example of a song that is like it's literally talking about like opioids and MDMA. That's the title of the song. Now this is kind of like a continuation of how blues communities in the 60s had really picked up opioids and alcohol use, and how we're going to come back to how like Black communities have previously been involved in opioid use, and the very complicated relationship that has with racial trauma. And again, like, I'm a white person talking about this, like my speeches on these things should be only as a signal boost for you to do your own research and like listen to the voices of the people that are impacted by this. So just like want to make that abundantly clear. So in looking at how opioids are being trafficked right now, I do not have the citation for this information. I've been looking for it, but as of a couple of years ago, at least, it was pretty typical that you could spend $3,000 to $5,000 in China on synthetics and machinery to produce synthetic opioids, which could then be imported into Mexico and distributed by cartels like the Sinaloa cartel, and then distributed within the United States. Anyone have a guess as to how much you could sell this $3,000 to $5,000 worth investment in the United States once it had been fully trafficked? Just guesses in the chat. I'll read them out loud. 100,000, second 100,000. Any other guesses? Looks like the 100,000s have it. 1.5 million. You can turn $3,000 to $5,000 into $1.5 million. But of course, the people that are at the beginning of the supply chain are barely making anything off of this usually. Like, that's just how the supply chain usually works, is that by the time the US gets it, so many people have had to be paid for it. And it's also such a dangerous market that you can basically price it as what you want by the time it gets to you. Now, we're going to go into a couple of the reasons why we're currently in the situation that we are with opioids. But before we do so, I want to say something about the phrase opioid epidemic. I do not use the phrase opioid epidemic. I say opioid crisis, and even that I feel weird about. And the reason is that in the 80s, when the crack epidemic started, it was not treated as a public health crisis. It was treated as a plague. And the demographic difference in who is predominantly affected by the opioid crisis, which has been deemed a public health crisis, as opposed to the crack crisis, which was deemed a plague that needed to be eradicated, is that the crack crisis was centered in Black communities and centered around Black culture. And the opioid crisis is just like in your neighbor's house with your elderly white grandma, who is, according to the US government and US society, in terms of how we look at drugs and the drug war, more valuable. So that's a really important thing to keep in mind when we talk about the opioid crisis and the way that public health has framed it. In the past, the crack epidemic was directly internalized as being a problem of morality, a problem of ethics, a problem of sacrilege. And here we are being like, oh, these poor, like everyone is suddenly like, oh no, we need to like offer treatment and detox and prevention measures. And that was just not on the table for the crack epidemic. It was just like, so differently handled. And yeah, it's later in history, but no, we don't treat similar issues of like racially segregated drug use any differently. And in terms of the opioid crisis, we're seeing a massive, massive spike of cases of opioid overdose reported in indigenous populations, where resources and access to healthcare is even lower than anywhere else. So I'm just saying, like, really, you should keep that in mind, especially when people are talking about like how not all drugs can be legalized, because it would be so dangerous. But then, like, simultaneously cherry picking which we're going to actually offer protective services for when people do them. Like, heroin is a white drug, largely speaking. Not entirely, obviously, but largely. Keys of fentanylogs were 6K from China. Yeah. All right, pill mills. So pill mills are basically doctors' offices where doctors basically have like an unspoken agreement with clients that they can just like prescribe opioids without any real causation. In many cases, you just like go right in, get a prescription or script, and dip out. Pill mills have become kind of like a staple in how we talk about the opioid crisis, in terms of people being like, overprescribing is the reason that we're here, but it's just not that simple. And we'll talk about why in a second. In terms of how the DSM, which is the Diagnostic Standard Manual, that's not actually the acronym, I don't think, in terms of like how professional psychological associations will decide opioid use disorder, like having an actual disorder around opioids, as opposed to just like having a problematic relationship with opioids or being a person who uses opioids. The use disorder is characterized by three things, which are dependence, tolerance, and addiction. And this is a really good example of how many media outlets and just people at large really fuck up the distinction between these three things. Dependence means that you have physical withdrawal symptoms. I should get rid of cravings. That shouldn't be in there. Dependence is physical withdrawal symptoms. Your body doesn't function the same without the substance present. Tolerance means you need more of it. And this is also wrapped under dependence, generally speaking. And addiction. And addiction is the mental component of things. It's the preoccupation, it's the craving, it's the desiring. And you can have addiction to something without being dependent on it. You can have those cravings for something without your body responding to the absence of it. And eventually, addiction does cause changes in brain structure in response to the stimulus, but it's not necessarily all because of the brain. We're going to come back to addiction and do a whole segment on it and specifically go into what we know about it now. The withdrawal from heroin in particular, but just opioids in general, I would say, the worst of it starts approximately like 6 to 12 hours after your last dose if you're a regular user. The worst of withdrawals for most drugs will be 1 to 3 days after you stop, and they will continue for a while. But what is very commonly reported from heroin and other opioids, by the way, I have many friends who have quit heroin who have not been able to quit cigarettes. Many people that say that quitting nicotine is much harder than quitting heroin. I just want to put that out there. The withdrawal timeline of opioids isn't necessarily the hardest part for people, or with any drug that you are having a withdrawal from. The hardest part is 3, 4, 5 months later. Oh, Jesus Christ. 3, 4, 5 months later, when you are like no longer in the throes of it and you're like, I feel pretty good about this, I can go back. Like I feel like I have a better handle on this. And that's where a lot of people have trouble. Now, for some people that works. For many people that doesn't work. It really depends on you as an individual, but that is the point where it gets a lot harder to continue going on. So a quick view into what going cold turkey is like.
When people say they have a near-death experience, they see their whole life flashing before them. It's kind of like that constantly, with all the bad stuff standing out. The first time I did an actual full-on cold turkey, it's 5 days of sheer hell. I was horrendously sick. crawling to the toilet every half an hour with green fluid flying out both ends simultaneously. Sweat went through 2 thick floor cushions into the carpet. It's really grim. But they didn't last very long because I didn't really want to stop taking it. I wasn't ready. And then things went crazy for about 5 years. So my last hit, it felt kind of like splitting up with a girlfriend that you loved a lot, but who was really bad for you. It felt hard to say goodbye, but I knew that I had to do it. And this is the place that will take everybody in, treat them as humans, patch them up.
A lot of the time the withdrawal symptoms of this is heroin, but like it really does apply to opioids as a class in general. Your body is responding to this like sudden lack of availability of a thing that has been providing a very profound systemic push down in a lot of areas and a push up in some areas in terms of dopamine activity as well. But one of the most common things that happens is like just feeling like the worst flu of your life, like terrible, terrible flu symptoms, muscle cramps, fatigue, vomiting profusely, diarrhea after a lot of constipation for a long time, probably, agitation, like body chills and shaking, and cramping. And it's just like profoundly, profoundly uncomfortable. And again, this lasts typically for between like 5 days and 2 weeks, depending. I would say closer to around a week, week and a half for most people, the worst of it. But it can continue after that. But again, it's like the post-acute withdrawal symptoms. It's the withdrawal symptoms that are really after that point where things can get like really tough to keep up with. Now, here is some of the most important practical information that I can give you in this course. In terms of opioid overdose in particular, because I know that everyone wants to talk about opioid overdose, and let's face it, there's fentanyl in a lot of shit right now, a lot of shit. In fact, we just got a report for those of you in Denver. We don't know what it is yet, and it might not be fentanyl, of unmarked round white pills with a score line on one side that put someone into a coma. And we're currently waiting on advanced testing evaluation to see what these white pills were, but the market is saturated, especially if you're buying on the illicit market. If you're buying on the dark net right now, you better be fucking careful. You should use with Narcan around. Like, no matter what it is that you're doing, you should use with Narcan around. Have someone do a test bump first. Test it with fentanyl strip first, obviously, but like have one person who feels like it do the first bump and have the other person on standby with Narcan until they have come up, just to be safe. The biggest risk of opioid overdose is a lack of oxygen. This is the main cause of overdose deaths, lack of oxygen. You should all know how to administer CPR at this point in time. I know it's complicated because of COVID. I get it, but you should all know how to administer CPR, at least in a basic sense. It's really important to know. The reason that this happens for a lot of people is twofold. The first is that you have an unexpectedly pure batch, like you've been using shit that is way less potent, and you get a new batch and it's just way more powerful than your old one. So your old dose is suddenly way more potent than you expect. Or you change your dosage quantity. You do more of it than you did before. And there's something else that we'll talk about in a second that's just about as prevalent as this. But then there's also reduction in tolerance. And sometimes people underestimate how long it will take their tolerance to go down. Or maybe overestimate. They incorrectly estimate how long it will take their tolerance to go down. Therefore, they do the same dose that they would have a couple of days ago, and that dose is too much. So opioids can be quite dose sensitive, especially opioids like heroin that are often injected, that are often in really low milligram quantities. Like the difference between 15 milligrams of heroin and 10 milligrams of heroin is really sizable. It's like a third of the dose is changed. But here is a really, really major thing. Compensation to your environment. I might have brought this up in the past, but this is possibly the most relevant place for it. when you are doing a drug in an environment as like your typical experience, if you use in the same place every time, generally speaking, or you have a history of using in one place, your brain will start to associate those environmental cues with what's about to happen to your body, and it will react. It will have a compensating effect. If your brain is like, oh, this sofa is affiliated with me doing heroin, doing oxy, doing morphine, doing codeine, that means that my blood pressure and my heart rate will go down. That means that my breathing is going to decrease. Therefore, to compensate for these effects, I'm going to increase my heart rate, increase my blood pressure, increase my breathing to help me combat this. Now, this is an effect that probably has happened with many of you who do drugs in something as simple as like smoking weed in the same room of the house every time. You might get less high than if you go outside and smoke the same joint. You're like, whoa, why am I so baked right now? Your brain keeps score on your environment. It keeps track of it. And this is a major reason why people overdose as well, is you can use the same dose that you would in an environment that's familiar to you in a novel environment and have it completely throw you off because it's just like not logged as an expected thing. Mouth to mouth has been deemed, mouse to mouse, listen to me. Mouth to mouth has been deemed unnecessary for CPR a few years ago. Yeah, the breaths for overdose. Yeah, that's good to know. But I think that, like people have said, for overdose, since the issue is a lack of oxygen circulation and intake, forcing oxygen is a really good thing to do. And Narcan, for those of you that don't know how Narcan or naloxone works, Narcan is the brand name for naloxone. Narcan comes as a nasal spray or an intramuscular injection. The nasal spray is most commonly going to be given out at like local organizations. There are many places around the country that are giving out free Narcan right now, so hit them up. You should all have some in your home as a good harm reductionist, and keep some with you wherever you go as a good harm reductionist. You can get it for free most of the time. How it works basically is it goes in there and it uses a crowbar and is like, party's over, and knocks opioids out of the receptors, reversing an overdose. It's really effective at what it does. If someone is really fucking OD'd, you might have to give them 4 or 6 little sniffs of Narcan. In this case, in the nasal spray, you do 1 spritz in each nostril. If they don't respond after a couple of minutes, you can do 1 more spritz in each nostril until they do respond. If someone is not brought out of an overdose by Narcan, it is unlikely that they were actually overdosed on an opioid. Like, Narcan's good at what it does. However, in the cases of things like xylazine, which I mentioned last time, which is a non-opioid sedative, or mixing with benzos, it's possible that a person would not be brought out of an opioid overdose if there were other depressant substances in their system that were not able to be removed. Oh, you held your Narcan up? That's awesome. Yeah, I really can't see. I can't see anyone but these 5 people in front of me right now. I see, I can't see your names. Okay, so the opioid crisis, right? Like this hot button. Oh man, I don't want to run out of time. I want to finish this. I'm so far from being done, guys. We're gonna have to do another session on opioids. The opioid crisis is not as simple as people think it is. It is just not as simple as like too many people doing opioids. People are getting addicted to heroin, or even someone started on prescription opioids and now they're addicted to heroin. It's just not that simple. Overdose is a part of it. Disease is a part of it. The economic impact is a part of it. This is a vicious cycle that is hard to demonstrate and hard to illustrate the tendrils of without like a massive map, which I would show you, but I can't because it's not finished. But this is a multifaceted issue. Let me give you an example. One of the major things that we'll go over in the opioid crisis is this. Wow, Jackson, over your shoulder, I thought that those were the butt and legs of like a person who was just jumping over the couch. And I was like, wow, that is a really strangely proportioned set of legs, but it's your dog. The opioid crisis, to give you an image of how this could unfold, one of the major reasons that it took place one of the major reasons that it took place was that in the 2010s, when the opioid crisis really started kicking off, doctors got scared of being held liable. Yes, we had overprescription, but we also had a lot of people that really needed their prescriptions. A lot of people, chronic pain patients who really needed their opioid prescriptions. And doctors suddenly were like, I don't want to get sued. I don't want to be responsible for this. So instead of providing an adequate tapering regimen, they would basically be like, you have a week. I'm not refilling your prescription. This would throw people into precipitated withdrawals. Just like all of a sudden, there were thousands and thousands of people who out of nowhere did not have access to this medication, did not have the ability to taper off of it. What else are you going to do? Especially if you're a chronic pain patient, and not only are you going to withdraw, but you're still going to be in pain to the point of not being able to do your job and hang out with your family and clean your house and feed yourself. So this creates this situation where people are forced, like people's hands are forced a lot of the time, not all of the time. In the case of prescription opioids, where people were kind of blindsided by this, into a situation where they would be like, okay, either I completely neglect all of the things going on in my life right now, or I do what I can to get what I need for the time being while I figure this out. And that's not always how it goes down. But in the case of some people who either just like didn't really fully understand what was potentially going to happen if they were using opioids on a regular basis, because regular consistent opioid use, it's pretty difficult to avoid physical dependence on them. Like if you're using them regularly, your body will become dependent on them, even if you're not addicted to them. So that's the same with benzos though, like people are really physically addicted to, physically dependent on benzos, even if they're not addicted to them, and have very few resources available to figure out what the fuck to do about it, especially if you're someone with a panic disorder and your doctor's like, I don't want to be held liable for this, I'm pulling your Xanax script. And then that person is then faced with the decision of like, do I find illicit market benzos, or do I face the possibility of having a panic attack in class? Like, what do I do about this? So a lot of this involves covering people's asses. And a lot of this involves the fact that overdose is completely avoidable with safe supply. Like high quality opioids are extremely unlikely to have a toxicity profile. They're actually pretty well tolerated by your body. If you use them long term, there could be some difficulties that arise, sure, but that's the case with most substances. When you're using high quality opioids, most of the risks of opioid use, except for physical dependence and the possibility of addiction, which is totally there. It's very real. Like addiction is a really major thing, obviously, although it's very dose dependent, very route of administration dependent as well. Although dependence is pretty much a guarantee, honestly, if you're regular, consistent use. The thing is, like, these problems could be almost entirely avoided. But then we also have to look at the cost of disease, of Hep C, of HIV. HIV, especially among people in the Golden Crescent. So the Golden Crescent that I'm thinking of in the Middle East. Is that the Golden Triangle? Ooh, I can't remember. The Golden Zone, number one. There are skyrocketing rates of HIV, especially among men who have sex with men, other underserved populations who are forced underground. Like disease perpetuates financial burden, perpetuates mental health burden, perpetuates the likelihood of other things going wrong, because those two things are deeply intertwined. And then the cycle continues because those people become fringe, they become marginalized, there becomes less advocacy for them. And this is just like this tumbling cascade of ugly, grubby birthday cake material that we're going to get into next time, because I'm over time. So that was, I guess we're doing another part on opioids, which is important because obviously this topic is so important right now and so poorly understood. I will stick around for like 5 minutes after class this time to answer questions. And other than that, I will see you guys on Thursday and have a great night. Dylan says Sui, I want to pronounce your name correctly. Sui, is that correct? It says Golden Crescent. Sui, did I get it right? Okay, thank you. It says it's the Golden Crescent, not the Golden Triangle. Golden Triangle is in Southeast Asia. Okay. Have a fantastic night, you guys. I'm gonna stop recording and I'll stick around for like 4 minutes.